All right, here we go. Hello, and thank you for watching this program on modifiers. There's no audio taping or videotaping allowed, and any unauthorized reproduction, dispensing, copying of this target coding presentation is illegal. The information in this presentation is for educational purposes. It's not intended to substitute your thorough clinical decision making. It's not intended to be legal advice. Target coding does not engage in providing legal services. CPT is a registered trademark of the AMA, and every attempt has been made to make certain that the information in this presentation is 100% accurate. However, it's not guaranteed. I'll tell you a little bit about myself before we get started. My name is Dr. Marty Kotler. I'm a chiropractor. I practiced for many years, about 16 years, and about 12 years ago I started a company called Target Coding. I'm the founder and the president of the company. I'm also certified in CPT coding. I'm a certified professional compliance officer. We've helped over 3,500 chiropractors and their staff members over the last 12 years with compliant coding and documentation. Our areas of expertise include HIPAA compliance, Medicare compliance, treatment plans, record keeping, and creating compliant cash plans. A lot of people think of me and my company as the insurance coding company. That's not true. We are the compliance company. We help doctors with compliance as it relates to billing, coding, documentation, HIPAA, Medicare. I've written 10 training manuals on chiropractic billing, coding, and documentation. I write articles for Chiropractic Economics, Dynamic Chiropractic, The American Chiropractor, the American Academy of Professional Coders magazine, and I also write articles for many state association newsletters throughout the country. Plus, I'm a guest speaker at many chiropractic state association conventions throughout the country. So let's go through the most common chiropractic modifiers. We're not going to be able to cover all modifiers in this presentation. We're just going to go through some of the most common modifiers used in a chiropractic setting. Now, the AMA owns the copyrights to the CPT codes and the modifiers. Now, a modifier provides the means by which a provider can indicate that a service has been altered. Something happened. There was some specific circumstance that is causing you to add a modifier. It could be to designate many different things. It could be used just to ensure payment. So there's a lot of reasons why you need to use modifiers. Now, if you were able to get away with getting reimbursed properly without a modifier, I'm all for that. So a modifier tells the insurance company that something happened. So again, that's why I like to teach my clients, if you don't have to use a modifier, don't use it. There are some providers that are using modifiers that are not necessary. They've been told to use them, or maybe the doctor bought a practice and the previous doctor was using modifiers. There are certain modifiers that are used that are not necessary, and one of them is Modifier 59. There are certain circumstances where it's not necessary to use, but yet doctors are using them, and it raises the profile and increases the chance of an audit. So modifiers enable healthcare professionals to effectively respond to payment requirements. So there's many reasons why you would need to use a modifier. Here's just a few. The service had a professional component. Only a part of the procedure was performed. There was a bilateral procedure performed. You have to designate to the insurance company that if it's a certain type of DME product, whether it's a rental period or it's a brand new device. Right side, left side. A service was provided more than once. A separate and distinct service. So there's many situations in which a modifier would be needed. So let's go through a few of them. Here we go. Modifier 25. This designates that a significant, separately identifiable evaluation and management service was performed on the same day as another procedure. Modifier 25 is only used on evaluation and management codes. There's an example on your screen. At the bottom of the screen, 99213, And now we have the 25 modifier. So 99213 is an E&M code. It's an established patient E&M code, typically used for re-exams, but not only for re-exams. And if you perform a re-exam on the same day as another service, for example, a chiropractic adjustment, you would need to append the 25 modifier to the E&M code, not to the chiropractic manipulation code. If you don't use the 25 modifier, there's a good chance the payer will bundle the two together. They'll bundle the chiropractic adjustment with the re-exam, and they'll only pay you for the exam. So this is a very important modifier. I'm sure many of you have had experiences where you've billed a 99212 or 213 without the 25, along with your other procedures like a manipulation or some therapies, and they don't pay for the re-exam, saying it was part of the other procedure. And then you resubmit the bill with the 25, and they pay it. So the 25 modifier is a way for you to bypass any type of bundling issue. Just got to make sure that your documentation could prove it was separate and distinct from anything else that was done. Modifier 5.1 is our next one, multiple procedures. There are some insurance companies that are still not paying for extremity adjustments unless you use the 5.1 modifier. Many, many years ago, when chiropractors would bill a spinal manipulation and an extremity adjustment, the insurance companies were not paying for the extremity adjustment, saying it was part of the spinal adjustment. Well, that was nonsense and ridiculous, so the recommendation was to put the 5.1 on the extremity adjustment, and that seemed to work. See, in my opinion, if you bill the extremity adjustment with or without the modifier, it's compliant billing, and that's the key here. You want to bill compliantly. Whether they pay or not is a different story. Of course you want to get paid. Of course you want to get paid everything that you deserve. But if they don't pay, then you go to Plan B. See, you want to bill properly. Whether they pay or not is a different story. Please understand, that's important. So there are some companies that still require the 5.1. Most do not anymore. Next, 52. Reduce service. This tells the insurance company that you did not complete the service. So I'm not a fan of this modifier. Yes, it should be used when indicated, but in my opinion, it should not be used on a regular basis. Let me give you an example. If a time-based code normally takes 8 minutes to perform, many insurance companies consider 8 minutes to 22 minutes 1 unit. So if you do it for 8 minutes, that's great. No modifier needed. You're meeting the time requirement. If you do something only for 1 or 2 minutes, then you may need to put the 52 modifier, but that should be a very rare circumstance. If you're billing the 52 modifier on a regular basis, that means you're not incorporating that service properly. Example you see on your screen, ultrasound 97035 with the 52. Why would I do that? Well, Mrs. Jones is coming in for, let's say, we're going to do ultrasound on her elbow because she has elbow pain, tennis elbow pain, swelling of the elbow. So we're going to do ultrasound. Okay, yeah, there's a clinical indication for it. So normally we do it for 10 minutes. No problem. Now Mrs. Jones comes in. We start doing the ultrasound. After 2 minutes, she says, wait, I got to go. Some situation occurred. Maybe she got to pick up her kids at school or something happened, and she could not complete the service. Okay, that's very rare, unusual circumstance. In that case, I would bill the 52. I would lower the fee a little bit, but it shouldn't be done on a regular basis. I know chiropractors, they'll do 1 or 2 minutes of manual therapy, and they'll bill 97140 with the 5.2 modifier. Not a fan of it. It could raise red flags. It tells the insurance company that you didn't complete the service. Why do I want to tell an insurance company that I'm not finishing the service? Something is weird. Next, 5.9 indicates a distinct procedural service was performed. Example, 97140. That's manual therapy. Most health plans will not pay if the chiropractic adjustment and the manual therapy, the 97140, are performed in the same anatomic site. So if you do the manual therapy in a separate anatomic site than the chiropractic adjustment, then in order to get reimbursed properly, you would need to put the 5-9 modifier on the manual therapy and come up with a separate diagnosis. Now, this 59 modifier has had issues over the years, so some things have occurred. Now, one of the most important things to understand about chiropractic adjustments is that they have CCI edits, correct coding initiative edits. So these edits created by CMS require that manual therapy, also massage 97124 and neuromuscular reeducation 97112 be performed in a separate anatomic site than the chiropractic manipulation. So if you do that, great. Then you're going to attach the 5-9 modifier to 140, 124, or 112 to indicate that it's a separate and distinct procedure being performed in a separate anatomic site with a distinct diagnosis. And that works great. It works pretty well most of the time. Yes, I know there are some companies that no matter what you do, even if you put the 5-9 and you have it in a separate site and you have a separate diagnosis, they still won't pay. Yes, I understand. I feel your pain. So Modifier 59 has had to have some evolutions because of the misuse of it. You see, think about it this way. It's one of those rare modifiers that bypasses the CCI edits. What do I mean by that? If you bill an adjustment and 97140 without the 5-9, most health plans will bundle the two together. And if you resubmit it with the 5-9, they'll pay. See, just adding the 5-9 will automatically allow the insurance company software to allow payment. So many providers are using the 5-9 recklessly because they feel, well, it'll help me get paid. Bad idea. Don't do that. A recent OIG, well, not that recent, it was probably about 6 years ago, an OIG report found that Modifier 59 was being used incorrectly nearly 40% of the time, resulting in millions of dollars of overpayments. So that's why it's looked at closely. Many of you may have been receiving letters from insurance companies saying, we are looking to see if you could send us notes on specific dates of service, and those are the ones that have the 5-9. There are certain insurance companies that track the amount of 5-9 modifiers you bill, and if they feel that you're above the normal amount, they're going to ask you for your notes. Now, if your notes show the separate region and the separate diagnosis, then you'll get paid. There's just going to be a delay in payment, but as long as you're doing it right, that's fine. So just be careful with the 5-9. As I mentioned earlier, some doctors are using the 5-9 on traction with an adjustment. Not necessary. I see some doctors using 5-9 on x-rays and exams. It's not necessary. You see, the doctors are billing the 5-9 just because they heard that's how you get paid better. But if you use it on an exam or traction on the same day as an adjustment and you're getting paid, you may think, well, it's working. No, it's working against you because your profile on the 5-9 will go sky high and it'll cause an audit to occur. So because of this confusion with 5-9, CMS has created this subset of modifiers. They're called the XESPU modifiers, and the one that makes the most sense is XS, separate structure, used to describe services that are separate because they're performed on different structures. That makes sense. So down the road, you may have to replace 5-9 with XS. I'm seeing it happen more and more. If you're using the 5-9 properly, continue to use it. Don't switch to the XS. But recently, I've seen more and more providers denying the 5-9 because they want the XS. Don't switch to the XS unless you're requested to, or you start seeing denials. So CMS will not stop recognizing 5-9, but it should not be used when a more descriptive modifier is available. Next, Modifier 76. What's this about? Well, have you ever adjusted a patient twice on the same day? So Mr. Evans comes in at 10 o'clock in the morning. He needs a chiropractic adjustment. He's in really bad shape, and you say, you know what, Mr. Evans? Wow. You got a lot of stuff going on. You know what? I want you to go home, rest, take it easy. I want you to come back later today. After dinner, come back about 6 o'clock. I want to adjust you again. I want to check you again. So you adjust Mr. Evans again, twice on the same day. Is there a way to get paid for it? Well, maybe. Modifier 76 is a repeat procedure performed by the same provider on the same day. So for the second adjustment, if you're going to bill for it, add the 76 modifier. See the example on your screen? See, if you bill 98940 with the same date of service twice without the modifier, most health plans will consider it a typo. You submitted a bill twice for the same date of service. With the 76, they say, oh, okay, the provider performed a second procedure on the same day using the same code. Now, most insurance companies will not pay for two adjustments on the same day. However, if you wanted to bill it for denial purposes, or maybe they'll pay, but if they deny it, then show it to the patient and hold them responsible if you're out of network. In network, you probably cannot do that. Next, Medicare modifier, AT. AT is a Medicare modifier. But wait, you might be saying there are some other insurance companies that are requiring it. Yes, don't use it unless it's required. About a year ago, Minnesota Blue Cross Blue Shield said to chiropractors, when you bill us for chiropractic adjustments, we want the AT. Wait a second, that's not a Medicare carrier. That's a Blue Cross Blue Shield carrier. Well, they made their own rule. They want the AT. So many of my clients in Minnesota, billing without it, it's coming back denied, and they don't know why. Because they're not reading their newsletters. They're not up to date on the latest changes and revisions that happen all the time. So I just tell them, don't worry, everything's fine. Just resubmit it with the AT, and they're getting paid. But it's a Medicare modifier. It stands for active treatment. When you bill AT, you're telling Medicare that it's active treatment. That means you know what active treatment is. You have to read the Medicare guidelines. Medicare modifier GA. That notifies Medicare that you have a signed ABN form on file. The ABN is used when a normally covered service is now not going to get paid. If you have some genuine doubt that Medicare will not pay, give the patient the choice to receive the services and offer the patient the ABN form to review. If the patient agrees to pay for maintenance care, which is the most common reason to use the ABN form, then have the ABN signed and submit the claim to Medicare if the patient checks option 1 on the ABN form. Example, 98940GA. Now, I brought up Medicare, so I just want to clarify a few things. I have a little test your knowledge right now. So, can you treat Medicare patients without being enrolled in the Medicare program? The answer is no. If you are not actively enrolled in the Medicare program, you cannot see Medicare patients. This is a shock to many doctors. I know many chiropractors that say, Marty, I'm not in Medicare. I don't have a Medicare number. I haven't billed Medicare in years. I just have Medicare patients come in, they sign the ABN form, they pay me, and I don't submit the bills. That's not okay. I hear that all the time. Dr. Kotler, I'm not enrolled in Medicare. I just charge patients cash. Isn't that okay? No. You have to be enrolled. You know what my recommendation is? Enroll in the Medicare program and then charge cash. But you must be enrolled. Can you collect cash from Medicare patients without billing Medicare? Is that possible? The answer is yes. Example. Medicare patient is on maintenance care. They sign the ABN form and they check option 2, which says do not bill Medicare. That's the way to do it. Next, can chiropractors opt out of Medicare? No. Opting out is a private contract. Chiropractors are not on the list of providers that can opt out. Can chiropractors opt out of HIPAA? Maybe. It depends. If you're not billing insurance and you're not receiving payments from insurance and you don't submit claims electronically, you might not have to abide by HIPAA. That's a whole nother ballgame. Now, getting back to, the use of the ABN form, a lot of chiropractors think that, I'll just have the patient, I'm not in network. I'll just have the patient sign the ABN form. Actually, if you are not enrolled in the Medicare program, you're not allowed to use the ABN form. What did you say, Dr. Kotler? Yes, I said that. Chiropractors are not allowed to use ABN forms if you're not enrolled in the Medicare program. Don't believe me. Don't believe me. Go to the Medicare Claims Processing Manual, Chapter 30, Section 50.3, under Financial Liability Protections. I've provided the link there, and you'll see chiropractors that are not enrolled in the Medicare program cannot use ABN forms. Chiropractors cannot opt out of Medicare. You don't have to believe me. Just go to the Medicare policy, Benefit Policy Manual, Chapter 15, Section 40.4, and you'll see chiropractors cannot opt out. When I bring this up, a lot of docs go, wait, I can't charge cash. I'm opting out. I'm non-par. I'm par. I'm non-par. I'm in-network. Make sure you know all the different descriptions. So when I mention to chiropractors they cannot opt out, they sometimes get a little confused. So I try and clarify it by taking the information right from Medicare. If you look in the bottom right corner, this isn't from me, this is from Medicare. It says doctors of chiropractic may not opt out of Medicare, noting that opting out and being non-par are not the same things. Chiropractors may decide to be par or non-par with regard to Medicare, but they may not opt out. I just wanted to clarify that just in case you had gray answers. Nobody could give you a good reason. So yeah, Medicare, again, I don't want to get too deep into Medicare, but Medicare does require that you put together policies and procedures to prevent billing and coding errors. See, maintenance care, that's what Medicare has found over the years. When they do their research, they're finding that chiropractors are billing with the AT modifier for active treatment, but their documentation shows that it's maintenance. So chiropractors are getting audited more than ever lately because of what's being found in the notes. And if you submit a bill that is considered not medically necessary, Medicare can consider that fraud or abuse. Yes, I know that's pretty crazy, but they can do that. So it's a good idea to have policies and procedures. It's not only good for the insurance companies. It's good for you, your office. Oh yeah, wait, here I have 3 reasons to have a policy manual on billing for staff. They want organization. Staff members want to work in ethical and trustworthy environments. I've done over 300 on-site trainings over the last 12 years throughout the country. I've been in a lot of chiropractic offices, probably more than most people on this planet, visiting offices all over the place. And when I speak to staff, they want organization. They want systems. They want to come in and have a nice, clean desk and have a very nice, trustworthy atmosphere that creates a culture of compliance. It's good for insurance companies. If an insurance company comes knocking on your door, let's say you see PI patients and a State Farm investigator comes knocking on your door saying, we have a complaint, or we heard you're not billing timed codes properly. If you have a policy and procedure on it, you can shut that down very quickly. See, you look bad and unprofessional if you cannot prove to an investigator, a state board, or even a patient what your billing and coding policies are. They must be formal. That means in writing and kept track of in training logs. And for the doctor, you want to create a billing and coding manual that tells your story in a professional manner. It'll definitely help you SWAN. That's one of my favorite acronyms, sleep well at night. So yeah, you should have a billing and you should have a policy on doing. Now, this is mandatory. If you see Medicare patients, you have to do your own internal reviews on patient charts. How do you know if you're billing correctly? If I were to ask you, do you bill properly? All of you are going to say, of course we do. Well, prove it. How do you prove it? The only way to prove if you're billing and coding properly is if you do a self-test and grade yourself. Now, this is an open book test, and you're going to score yourself. Don't you think you're going to give yourself good scores? If it's an open book test that you can score yourself, are you going to give yourself a 52 and fail? No, you're probably going to score well. So we have this score sheet, this audit tool that should be used. If you see Medicare patients, you are required to go to the Medicare exclusions site to see if the person that works in your office has been excluded from the Medicare program. Put your own name. Go to exclusions.oig.hhs.gov. Exclusions.oig.hhs.gov. Go to that website. Put your name in the field to see if your name pops up. If your name is Dr. Godfrey here, you have been excluded. Oh, actually, this is a nurse. Douglas Godfrey is a nurse who's been excluded from the Medicare program. If Douglas Godfrey came into your office looking for a job and you put his name in this website, you would not be able to hire this person if this person is going to be treating or be involved with Medicare patients. Yeah, and you should also have just in your HIPAA notice, if you have an open therapy room, put it right in your HIPAA notice. We utilize an open adjusting room. We make good faith attempts to keep our conversation at a low level. We offer every patient the opportunity to be treated in a private room. How do you adjust full spine? Do you adjust full spine but you only bill for one region? That should all be in your policy. Okay, so back to modifiers. Let me show you a sample claim form with modifier 59. That's the most common modifier. So if you look at these lines, you'll see the first line is a chiropractic adjustment, 98940. That's pointing to A and B. Diagnosis codes A and B are lumbar diagnosis codes. M54.16 that's a disc disorder with lumbar radiculopathy. And the adjustment is also going to M62.830, which is muscle spasm. Then the next line item is 97140 with the 59. That's pointing to diagnosis codes M5412, which is cervical radiculopathy, and it's also pointing to M79.1. which is myofascial pain. So that's why I'm doing the manual therapy to work on the myofascial pain. And then the next, and you'll see the 59 pointing to separate diagnosis codes. Then the next line item is electrical stim. We're doing that where? On E and F. M51.34 is thoracic disc degeneration, and M54.6 is thoracic pain. So I'm doing electrical stim only on the thoracic. Next line item, therapeutic exercises, 97110. Where am I doing that? Just on the lumbar region. 98941. Here's a Medicare example with the AT modifier. And then 97012, GY. GY is another Medicare modifier that tells Medicare that this is a non-payable service. Please submit it over to the secondary. It'll come back properly processed, which means it'll come back with a PR, which stands for Patient Responsibility Remark Code, so you can charge the patient cash for the traction. All right, just a few closing comments, then we'll open it up to questions and answers. You must check with all the carriers you bill prior to submitting claims based on the information provided in this presentation to ensure that it is compliant. Target coding does not guarantee this information will guarantee payment from any insurance company or patient. Target coding is not responsible for any laws, rules that change following this presentation. You know they change all the time, so it's important to do your best to stay on top of these changes, attend seminars, webinars, and join your national and state professional associations. Here's our contact information, info@targetcoding.com, website targetcoding.com. Oh, yes, HIPAA. We offer HIPAA compliance programs. I haven't mentioned that. Just a couple of minutes here on HIPAA. HIPAA is a federal law. It's required if you are a covered entity. What is a covered entity? If you bill insurance or you get paid by insurance, you are considered a covered entity, which means by law, you have to abide by HIPAA. HIPAA is good protection. It shows you how to protect your patient files. It shows you how to protect your practice from a staff member becoming disgruntled. It shows you how to prevent staff from stealing information from your practice. It could prevent HIPAA complaints from patients. It's a good thing to do. It's mandatory. Our program is different than any other program out there. So if you're shopping around for a HIPAA program, make sure you're comparing apples to apples. We consider ourselves like a car dealership that sells Mercedes. Hondas are terrific. I love Hondas. We don't sell Hondas. We sell Mercedes. And we offer billing and coding compliance manuals. We now do acupuncture, billing and coding seminars, webinars, and compliance manuals for acupuncturists. We're going to be doing a lot of acupuncture billing, coding, and documentation presentations starting next year. And of course, we have Medicare policies and procedures and a very nice, simple OIG compliance manual. If you are interested in that, let us know. We also sell a book on the best chiropractic ICD-10 and CPT codes to improve reimbursement. It's an excellent book. It's our bestseller. It provides you with information on how to pair your codes. Like you pair wine and food, we show you how to pair your CPT codes to your diagnosis codes. We also provide you with diagnosis codes that pay for the most visits, long-term treatment diagnosis codes. The book also has these really cool cheat sheets. It also gives you a little clinical section. So if you're going to diagnose a patient with cervical radiculopathy, it tells you to just do a little Jackson compression, a little Valsalva. You're going to diagnose a patient with cervical brachial syndrome. Do Wright's test, Atson's test, a couple of ortho neuro tests, check for myotomal weakness, check reflexes, forward head posture. This way you can justify the diagnosis code you're billing. We also have a FAQ section. I've been gathering these questions for years. For example, what's the difference between effusion, swelling, and edema? What's the difference between myalgia, myositis, and myofasciitis? What's the difference between a disc disorder and disc displacement? What's the difference between cervical brachial syndrome and cervical radiculitis? Yes, we also do seminars all over the country. We have a ton of seminars coming up. We're just in the process of completing our 2018 seminar schedule. Most of our webinars are approved for CE credits and seminars. And we also offer a free 15-minute practice evaluation. Give us a call or send us an email. Let us know you want to set up a 15-minute call. No charge, and we'll just shoot the breeze. Whatever you want to talk about regarding compliance as it relates to billing, coding, documentation, HIPAA, and Medicare. 15-minute, no charge. Pick my brain for 15 minutes. Again, here's our contact information. Thank everybody for attending. Let's take a look and see what questions have come in.